Okay, what we're going to be talking about today is protocols for the neck and for the spine. This comprises cervical spine, thoracic spine, and lumbar spine. And I'm sure that you will be doing your fair share of both soft tissue necks as well as cervical spines, as well as thoracic spines and lumbar spines. Everything is quite common in this. And many times the protocols actually just get simplified down into like a soft tissue neck and cervical spine and things like that. And there's not a whole lot of this specialization like we'll see throughout. But once again, that kind of depends on your department protocols. And as you'll see, there's not a whole lot of protocols in comparison to what we've actually been covering. So this week will kind of be a shorter lesson week in terms of protocols. So if we first begin, we're going to look at the nasopharynx and the oropharynx, a protocol for that. And we see that this can be in relation to a tumor, an abscess in the naso or oropharynx, salivary gland masses, and skull-based lesions. We'll see later that we do have some salivary gland protocols as well. And so this is kind of something that just comprises everything. The patient position is going to be pretty much the same throughout all of our protocols, with the patient being supine, the arms by their side. The key thing here is the removal of dental prosthesis. And you might be sitting there wondering why this is actually something that we have to watch out for. But if we refer to this image, we see that we have a dental prosthesis here and here, and then on the sagittal view we can see a large area. And while this doesn't look that significant, when you're actually scanning through, it will really decrease the amount of image clarity, I guess you would say, that you're going to see in this area. And so it can throw all kinds of scatter and artifactual information or noise in this. And so it can really make looking at the level of anatomy in this area very difficult. And as we can see, this would kind of fit in the level of C1 and C2. Here is C2 with the odontoid process. And so if you'll notice, it's almost in the same plane. So this can be very detrimental to diagnosing the patient. So with that being said, the anatomical range that we're going to see is the frontal sinus to the superior mediastinum. And as we were looking at our image, here's the frontal sinus. And superior mediastinum is usually taken to mean around the aortic arch. And so somewhere around here is the aortic arch. And so notice we're going just slightly below it. On your sagittal image, you want to make sure that you're getting all of this area and not just the spine. So we're getting all of the neck, and we're also getting into the facial region as well, because as we'll recall, this is for salivary masses as well. And so we're looking for the nasopharynx right around here, oropharynx. And so we're trying to get all of these areas. As we continue on, we see that the patient's respiratory instructions simply are breath hold and inspiration. The reason we strive to, especially for this scan, to have the patient hold their breath and inspiration is because even subtle, slow breathing can actually cause motion in the structures that we'll not be looking for. As we venture into just trauma cervical spines and things of that nature, we'll see that the breath holds really don't hold as much of value as they do with this, because we're looking at other structures other than just the bony anatomy. For this, because you're looking for things like abscesses, salivary gland masses, things like that that will hold contrast very well. we will use contrast enhancement. And if you'll notice, this is 100 milliliters at 3 milliliters per second, which means that it's going to take you around 35 seconds to actually get the full amount of this contrast injected. So that brings us to the delay. The delay is going to be 40 seconds from the initial point of injection. So as soon as you start the injection, most of the time your computer that operates your CT will actually begin timing you based on that. And so it will actually allow you to scan at 40 seconds. The collimation is 64 by 0.6 millimeters, so you're going to get 64 slices by 0.6 millimeters. However, based on your scanner type, you may get a little thicker collimation with less slices, but that's perfectly fine. The pitch is going to be 1, and the important thing to notice here is that we're going to use bone windows for skull base assessment. And the reason that becomes valuable is, if you'll notice the scan field, we're going to actually get a large portion of the skull in this area. And so because of that, and because of what we're looking for, such as skull-based lesions, we definitely need to utilize bone windows, which are going to make those lesions stand out in comparison to just typical normal anatomy. So that brings us to looking at the larynx and the hypopharynx. And so we see that the reason to perform this scan is laryngeal inflammation, laryngeal tumors, a laryngocele, or hypopharyngeal tumor. So basically what you're looking for is masses in a very specific region in the larynx. And so once again, the patient is going to be down, laid down supine with their arms facing down or their arms down. And another key point is to remove the dental prosthesis. We've already covered why you would remove it, and so it's just something you would typically want to do. The anatomical range is from the mandible to the subglottic region. However, it's kind of hard to differentiate where the subglottic region will be when you're looking at these two images. And so basically the easy way to kind of get this anatomy is from basically the mandible to the superior portion, or the apices of the lungs. As we can see, the apices are in this area. We're scanning slightly below that, and notice that the crana is here, and so we're getting almost to probably 3 to 4 centimeters above the crana. So we're getting pretty much all of the larynx and actually a little bit of the trachea as well. So we can be assured that we're getting all of the anatomy that we need to get for this. And once again, remember that this is for a very specific portion of the skin, or a very specific portion of the anatomy. So the patient's respiratory instructions are breath hold and inspiration, then an E phonation. So basically, keep in mind that you're going to be performing 2 scans for this. And so the first one is going to be just with simple breath hold, and then the second one is going to be kind of saying the letter E and holding it for the full amount of the scan. So it would be E as you're scanning. Notice that you're utilizing 100 milliliters of contrast. This is not supposed to be per second. That would be very bad. But this is supposed to be for 3 seconds, 3 milliliters per second, which once again gives you around 33 to 35 seconds for injection. We will begin the scan at 40 seconds, However, because you're doing 2 scans, it's very essential that you do those back to back very quickly. And so there's no time to delay doing the second scan. So as soon as you get the breath hold inspiration scan done, then you need to go ahead and do the E phonation scan as well. The collimation is going to be, once again, 64 by 0.6 millimeters. Pitch is going to be 1 as well. Looking at the comments, we see that careful instructions is essential to success. Perhaps careful instruction is the most essential quality in providing excellent scans, because if the patient doesn't understand the instructions or what we're actually doing, then usually that will cause the scan in itself to be a total disaster. And so it's essential that we use careful instructions. We also see that E phonation and breath hold scans are essential when infiltration of the cord is suspected. Shallow breathing and the Valsalva maneuver sequences may also be necessary. So some of you may kind of question what the Valsalva maneuver actually is. So what it is an attempted exhalation of breath with a closed airway. And so basically what you do is you close your mouth and then you pinch your nose shut and then you attempt to exhale. And so this is going, usually it's used for demonstration of how the cardiac function actually is in relation to the autonomic nervous system, but it can also be used for a scan like this. So that might also be necessary. And basically, we also see for nodal staging, a neck study is an essential adjunct. And so basically, it's essential that we do the scan if you're wanting to stage some type of cancer in this area. And so this becomes very essential. That brings us to a routine neck. Indications for this are cervical mass, lymphadenopathy, lymphoma staging, and restaging. So as you'll see, a routine soft tissue neck is usually utilized for evaluation of masses and things like that. The patient position is still the same, with the patient being supine with the arms down by their side, and also remove dental prosthesis. The anatomical range is going to be a little different on this, from the superior mediastinum, which we've already covered, around the aortic arch, somewhere in that vicinity, to the hard palate. If you'll notice, the anatomical range is kind of reversed, and that means that typically how we're going to be scanning is from the mediastinum up. And so our scan is going to be going reverse to what we would typically think about. The reason for this is because, as you'll remember, in the aortic arch, there are several bifurcations, and some of those bifurcations are the carotid arteries, which are going to supply the head and the face. And so it's essential that we catch the flow as it's going up, not coming from the head down, because we might potentially miss areas where the flow has not got to yet. So by doing this, we can ensure that we are actually getting the scan data correctly, and we're actually getting contrast enhancement as we should as we migrate towards the head. Once again, in relation to the hard palate is taken to mean this area here, but usually I like going up a little higher, going into around the sella area. Here would be where the sella turcica is, and so if you go up into this area, you can be assured that you have actually got all of this anatomy that you're looking for. Once again, patient respiratory instructions, breath hold and inspiration if the patient can do this. However, not all patients can do that. Some may not have the capabilities to hold their breath for the full amount of time, and if that is the case, then absolutely gentle breathing can be allowed, but definitely no swallowing. If a patient swallows, that will truly mess up the scan and ultimately provide great inconsistencies in the data. Contrast enhancement, once again, is the same as it's been for the first two scans. 100 milliliters, 3 milliliters per second. Image timing is going to be about 40 seconds. So the scanner is going to take off after 40 seconds from the initial injection. Collimation, once again, is 64 by 0.66 millimeters. Pitch is 1, and that is it for this scan. The parotid gland. As we'll see, this is very specific. The parotid gland is situated between the EAM and the mandible, or the sternocleidomastoid muscle and the mandible. And so we're looking for this vicinity. Scanner settings, or first the indication is for a tumor or an inflammatory disease, such as an infection of this gland. The scanner settings are going to be KBP around 140, MA going to be around 250 to 350. All of this is variable depending on the patient size and age. Oral contrast, there's no need for it based on what we're looking for. Phase of respiration in terms of this is quiet breathing, because it really is not going to affect this area at all. A rotation time for the tube is going to be 0.5 to 0.8 seconds, and keep in mind that this is the amount of time that it's going to take to acquire one rotation of the tube. But this is also based on manufacturer's settings for the scanner, and so not a lot of this can be manipulated. The acquisition slice thickness is going to be 1 to 2.5 millimeters, and the pitch is going to be 0.75 to 1.5. 0.75 is going to mean that you're overexposing some parts of the anatomy, whereas 1.5 is not going to overexpose the patient's anatomy. The trade-off here is that you're dealing with small areas, and 0.75 is probably going to yield slightly better images with reduced noise, but the trade-off in dosage is probably not going to be something that you want to compromise on. Reconstruction slice thickness is going to be 2.5 to 3.0. Notice that our acquisition slices are 2.5, and so that means that the smallest, if we use 2.5, is going to be 2.5, but 2.5 to 3 millimeters is going to be a sufficient type of thickness for this. The anatomic coverage is from the bottom of the sella turcica to the hyoid bone. Sometimes the hyoid bone is a little difficult to differentiate. Usually lies around T4, T5, somewhere in this vicinity. And so if we look, here's 1, here's 2, 3, 4. So we're around 4, and there's where the hyoid bone is. It's a little difficult on an AP view to actually distinguish where the hyoid bone is, so it's always easier to really kind of plan it out on the sagittal view. And make sure that you're in the range of the sella turcica. Here is the sella, and so we are right above it in terms of the scan. IV contrast is going to be 100 milliliters at 1 milliliter per second, and as you will see, the delay is going to be 60 seconds. So as you're scanning, you're still going to be injecting the patient with contrast. Minimum catheter size based on this flow rate of 1 milliliter per second. A 22 gauge should be sufficient. We always strive for smaller gauges like an 18 to a 20, which means when we decrease in gauge size, we're actually getting larger IVs. We strive for larger IVs, but a 22 will be sufficient for this based on the reduced flow rate. Another thing to keep in mind is the scan angle. You're going to be We're going to be scanning at the IOML at this angle. And so you're going to be looking something like this. Without that last line running kind of crazy. But you're usually going to be scanning at the IOML and parallel to the long axis of the mandible. However, if you're unable to scan at an angle, then basically what you do is you scan the patient straight, and then you basically angle the reconstructed scanned images. There is some argument that the second way of doing this by scanning straight and then angling is actually better at producing excellent diagnostic images than scanning with an angled gantry. And so that is the frame of mind now, that basically we scan straight and then we angle our reconstructed images. Also, key thing to keep in mind is that you film all images in soft tissue windows and only the images through the skull base and bone windows. So, as we can see, here's the skull base, and so we would film those images in bone windows, and then as soon as we got out of that area, we would film pretty much everything in soft tissue windows, and only the small portion in bone windows to look for lesions at the base of the skull. Looking at the soft and hard palate can be as a result of tumor inflammatory disease or infection as well. Scanner settings are going to be much the same as we saw for the parotid gland. KVP going to be at 140 and MA around 250 to 350. Once again, oral contrast is not utilized, and the phase of respiration is quiet breathing, because small shallow breaths will not really disrupt what we're trying to see. Rotation time and acquisition, rotation time is the same as we saw before. Acquisition slice thickness is slightly different, with the minimum slice thickness being 1.0 to 1.25, so we're utilizing very small slices. Pitch is 0.75 to 1. The reconstruction slice thickness is 2.5 to 3 millimeters. Usually 3 millimeters can be utilized. However, some facilities use 2.5. It's really at the discrimination of what the facility chooses to use. Both are sufficient for this anatomy as well. The anatomic coverage is much the same as the parotid glands, from the bottom of the sella turcica to the hyoid bone. So once again, notice where these landmarks are and just utilize them for a scan like this. IV contrast is 150 milliliters at 1 milliliter per second. So we're injecting a larger portion, and it could be argued that 100 milliliters would be sufficient, and I kind of feel that 100 milliliters would be very sufficient based on this anatomy. However, the book says that 150 would be utilized. Notice we're scanning at 60 seconds, so at 60 seconds we've only injected 60 milliliters. There's still 90 milliliters left to inject. That's why I feel that 150 is slightly off base. Because of the decreased flow rate at 1 milliliter per second, we can still utilize the 22 gauge catheter. Once again, the scan angle is going to be at the IOML and parallel to the long axis of the mandible. And so basically you'll scan like this, and then parallel to the long axis of the mandible, which would be this, and kind of fits the angle of the C-spine. However, it must be stated once again that usually you scan pretty much straight. You don't angle the gantry, and then you utilize your NPRs to performed angulation. So all of this is done in the pre-processing or the post-processing portion of the scan. Also notice that NPRs are essential, which means that utilization of coronal and sagittal imaging as well as obliques is pretty much mandatory. There's no way that these will not be helpful. So that brings us to a neck survey. As we'll see in the indication, this is kind of looking for things that we think could exist but not really, knowing for sure that they do, such as a neck mass that has suddenly arose on the patient. I see that a lot of times where a knot has just kind of come up on their neck, and you're wanting a better definition of what is going on with the patient. Also, lymph node surveys, lymphoma, unknown primary type of cancer, skin cancer, melanoma, all of this can be used for a neck survey. The scanner settings, once again, are going to be 140. MA is going to be slightly different from 220 to 260. Once again, no need for oral contrast. The phase of respiration is once again quiet respiration. Rotation time for the tube is 0.5 to 1 second. The acquisition slice thickness is 2.5 to 3 millimeters. So we're acquiring a little thicker slice thicknesses, and it can be argued that at 2.5 to 3s, you might not actually get as good of NPR reconstructions, so it could be utilized even thinner slices than 2.5s. Once again, it's usually your department protocol how it's actually set up. Pitch is 1.0 to 1.5. The reconstruction slice thickness is mirroring the acquisition slice thickness at 2.5 to 3 millimeter. And the anatomic coverage is the top of the celothurcica to the lung apex. And so you're looking for the lung apices, which are in this area. And your sella is right here. So the question becomes, how do you plan this out with each portion of the scan kind of demonstrating, or each portion of the survey kind of demonstrating essential anatomy but not on the same page? Basically what I do is I'll line that go all the way down to the apex or the apices of the lungs, and then I use my sagittals to kind of broaden out my scan field up to the top of the celothurcica. So we're covering all this portion. Also, I want to say that if a patient has an unknown mass on their neck that has steadily enlarged itself, it would not be a bad idea to utilize BBs. I'm sure we've each saw the BB markers, and basically what you can do is put it on the superior and inferior portion of this enlargement, and that way it will give the radiologist kind of a heads up on where this mass is, and so that they can get a more precise location. IV contrast is going to be 100 at 1 milliliter per second, very slow flow rate, which allows us to utilize a very, very tiny needle in a 22, and possibly you could even go up to a 24 gauge for this patient. The delay for the contrast is going to be 60 seconds, so the scanner is going to begin scanning 60 seconds after the initial start of the injection. We also use or utilize the IOML for scanning through the superior portion, and then you scan parallel to the long axis of the mandible, which I feel that we've already covered what that means. This scan is almost debatable whether it applies to the brain or it applies to the neck, and so we'll include it with the neck, but it's possible that this could apply simply to the brain as well. And this is for a suspected cerebrospinal fluid leak. An indication is cerebrospinal fluid autourea and or rhinorrhea. Scanner settings are going to be KBP at 140. MA is going to be 300 to 400. Oral contrast, once again, is none. And it's going to be acquired with quiet breathing. The patient also is going to be situated supine with their arms down by their side. The rotation time for the tube is going to be 0.5 to 1 second. And the acquisition slice thickness is going to be very thin at 0.5 to 1.25 millimeters. Usually the thinner slices are actually utilized here. Pitch is at 0.75 to 1.0. The reconstruction slice thickness kind of mirrors our acquisition slice thickness with being 0.5 to 1.0. So typically you want to utilize very thin acquisition slice thickness so that you can utilize thin slice thickness for your reconstruction as well. The anatomic coverage is going to be from the top of the frontal sinus to the hard palate. So this is why it's kind of debatable whether it actually applies to the neck or not. We're going from the frontal sinus to around this area here. As we'll see, it corresponds to this area, and we're going slightly above Cervical at the frontal sinus. As we can see, it's a little easier to kind of demonstrate on the AP view for this type of scan. IB contrast, we're not even going to utilize IB contrast or anything. This is just typically a very fast scan. This is a very common scan, one of the most common that you will probably see in addition to the routine neck. Those two are very common. And we see that this is for trauma, neck pain, degenerative disc disease, benign or malignant tumors, infectious disease. All these things can be kind of coupled together for a cervical spine. The scanner settings are going to be KBP equals 140, and the EMA is going to be 220 to 240. Sometimes this is based on if the scanner is equipped with a type of program that will auto adjust the EMA based on what type of anatomy you're going through. So this can be variable. Oral contrast, once again, is none, and the cervical spine can be acquired with quiet breathing. Rotation time for the tube is going to be very quick at 0.5 to 0.8 seconds. The acquisition slice thickness is going to be 1.0 to 2.5, and the reconstruction slice thickness is going to pretty much mirror that. Usually 2.5s are actually utilized for the cervical spine in reconstruction, and they prove to be very adequate. The anatomic coverage, the books kind of go a little different than typically what is actually done in the field. The book says 1 disc space above the level of suspected pathology to 1 disc space below the level of suspected pathology. However, the problem with this is that we're not really in the position to suspect pathology or anything like that. We're in the business of acquiring images. And so based on that fact alone, it's very inadequate for us to actually do this suspected pathology. So pretty much what is done for a cervical spine is the entire cervical spine is imaged from the Thoracic to T1 to T2, and then usually we reconstruct the images of the entire cervical spine, and then if you need to focus on the area, you can actually extrapolate the data for that area and then focus more on it. That way all the bases are covered, and so that the patient is not only getting just a small portion of the scan. Here we can see that we're above the sella turcica, and we really can't tell where we're at on the sagittal image because the patient has kind of broad shoulders. However, we can see that we're below the apices here, and this looks like T1, so actually we can move this up a little bit to T2. Usually for cervical spines there is no injection of IV contrast, which means that there's no delay or catheter size that needs to be utilized. Reconstruct images in a plane parallel to the disc space, or you use multi-slice axial imaging mode. Basically what we do is reconstruct based on disc spaces, which can be sometimes quite tedious because you're looking at this space here, 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 and you have to hit those angles. So many times it will require piecing together several different scans after the initial scan to kind of go through these disc bases. Also, it's very important to note that we should film both bone windows and soft tissue windows because what the patient is actually getting, if we'll look at this image, they're actually getting a routine neck or soft tissue neck as well, based on the anatomy that's covered. And so you can actually use this scan to knock out two different types of scans as well. Okay, extracranial vasculature. As the name implies, it's vasculature that is going towards the cranium, but it's not in the cranium. So this can be for vascular stenosis or an occlusion, aneurysm, malformation, trauma, things like this. And so basically what we're focusing on is the carotid arteries and or the jugular veins. The scanner settings for this are going to be kbp 140, MA around 300 to 340. Basically what this is used for is because usually you're going through a thicker portion around C6 to C7. That's going to be a very thick portion of the body, and so you're going to need tons of penetration. And if you have a machine capable of variable MA or variable mass, then this will kind of decrease the mass as you're going through the neck, and the neck gets thinner. Once again, oral contrast is none, and the respiration is quiet breathing. Rotation time is pretty much the same as we've been talking about. The acquisition slice thickness is 1.0 to 1.25. We're still utilizing thinner slices, and that brings us to the reconstruction slice thickness being 2.5 to 3.0. Usually for this type of scan, 3.0 will be sufficient as well. The anatomic coverage is going to be from the skull base to C6 vertebral body. As we know, when we get to the skull base, that is where the vasculature is actually entering into the cranial area, and so this would be considered intracranial vasculature, not extracranial vasculature. However, we do go slightly above the skull base. This would be defined as the skull base, but including some portion of the occipital bone would be applicable. We also count down vertebrae. It's kind of hard to do on the axial scan, but we go 1, 2, 3, 4, 5, and then this is 6. So we're covering the anatomy, and actually we're getting probably down to C7 here as well. The IV contrast is going to be at 100 milliliters, and we're going to increase the flow rate at 3 to 4 milliliters per second. Notice as we've increased the flow rate, we've also decreased the delay from 40 seconds to 20 seconds. And because of all of this increased flow rate, we have to utilize little larger IB. So instead of a 22, we have to utilize a 20 to actually be at maximum efficiency. In terms of the comments, we should perform data processing using maximum intensity projection technique and display the data in 3 dimensions and various angles. So basically what we're looking for is vasculature abnormalities, and because of that, maximum intensity projections kind of allow the vasculature to stand out against all of the soft tissue structures. So that's what we would typically use for this. So the thoracic spine. This is typically utilized to evaluate suspected fractures. The KVP is going to be 120 to 140, and the MA is going to be 200 to 300. And this is all going to be dependent on the type of patient body habitus that you have. Or contrast is not utilized for a thoracic spine. However, we're going to notice that for a thoracic spine, we need to suspend respiration. Usually the patient takes in a big deep breath and they hold that breath while we scan. The rotation time I feel is slightly off, 15 to 30 seconds. So we're going to kind of cancel that out because it will not take the 30 seconds to rotate around the patient. Scan will be done before 30 seconds is up. The acquisition slice thickness is 1.0 to 2.5, and usually it can even be slightly lower than 1.0, but I think 1.0 is usually a good and happy medium to scan on. And that brings us to the reconstruction slice thickness. Usually 3s are utilized because of the amount of storage space that 1 millimeters would actually take up in terms of packs. So it's much more efficient to utilize 3 millimeters, and if there is some abnormality, you can always go back and recon into 1 millimeters or 2 millimeters. Anatomic coverage is going to be several centimeters above and below the area of interest. However, once again, we don't really know what the area of interest could be. And so it's much more efficient to scan the entire cervical area or entire thoracic area. And so we find that usually when you have an order for a thoracic spine, it means simply from C7 to L1. So that compromises all of the thoracic spine. And we can see this kind of bore out in our images below. Here is T1. So this is probably 7, so we're safe in this area. Sagittals are a little harder to really figure out where you're at. And so basically sagittals are utilized to make sure that you are getting spinous processes. Sometimes that's hard for techs to actually grasp that what you're doing on the sagittal image is verifying that you're in the scan plane that you need to be, and so you're getting all of the anatomy. If you coned in too much, then there's a strong chance that you might actually miss some essential portion of the anatomy. So it's okay to leave the collimators open and wider, like what you see here. So if IB contrast is actually utilized, it will vary case by case. Usually for thoracic spines, they're not utilized, but if so, 100 to 150 milliliters at 2 to 3 milliliters per second. However, I once again stress that thoracic spines are usually performed without contrast. In this case, though, if contrast is utilized, 60 to 70 seconds would be sufficient. And because of this high flow rate, or a higher flow rate than 1 milliliter per second, it'd be safe to utilize a 20 gauge needle. Many manufacturers say that a 22 can take up to 3 milliliters per second, but I feel that you'd be pushing it, so it's always better to utilize a 20 gauge if possible. In looking at the lumbar spine, we find that the protocol is very much similar to what we saw with the thoracic spine. We'll kind of cross out the rotation time. The slice thickness is still very much the same, and basically we see that once again we're told to include centimeters above and below the area of interest. However, in terms of the lumbar spine, it's essential to include all of the lumbar spine. So this usually means T12 to S1 or S2. And when we're saying S1, we're talking about the levels of the sacrum. However, I like to go probably about midway through the sacrum so that you can verify that you're getting all of this area. And so usually both sagittals and coronals are useful in planning this image out. We see that this is probably T12 here. So we're getting T12, and the beginning of the sacrum happens here. So we're at 1, 2, 3, 4, 5. So we're including all of this area, and if we refer over to our sagittals, we see that we have 5, 4, 3, 2, 1, T12. We're actually getting a little bit of T11, but we're including the T12 vertebrae in its entirety. Once again, lumbar spines are not usually performed with iodinated contrast. However, if that is the case, then usually 100 to 150 milliliters at 2 to 3 milliliters per second will be sufficient. The delay is going to be 60 to 70 seconds to allow this contrast to get to the area that we would like, and 20 gauge angiocatheter will be needed for this as well. Okay, this is a study that you may or may not see, myelographic lumbar spine, and this is a myelographic study. Scanner settings are going to be KBP 140, MA 300 to 350. MA gets bumped up slightly because of the area that you're going to be scanning through. Oral contrast, none. Phase of respiration. Based on what you're trying to visualize here, suspended respiration would be beneficial. Rotation time is once again very high, and so just kind of mark this out and don't worry about the rotation time for this. As we can see, the acquisition of slice thickness is 1.0 to 1.25, and we're going to recon in 1.25. So we're wanting to utilize these very, very tiny slice thicknesses for this based on what we're trying to visualize. Basically, it says, the book says that you should only view the area of interest, but my thoughts are that you would visualize the entire lumbar spine area. However, there will be a radiologist there that is performing this, so it will be kind of at the discretion of what the radiologist says. Okay, the IV contrast rate is going to be 100 to 150 at 2 to 3 milliliters per second at 60 to 70 seconds for a delay. And the minimum catheter size is going to be 20 gauge. So our final scan that we will be talking about is a trauma cervical spine. It kind of mirrors the cervical spine that we had already discussed. And as we can see, this is a trauma screening. Scanner settings is going to be KBP 120 to 140, and MA is going to be 200 to 250. No oral contrast, and it's going to be performed at suspended respiration. Rotation time is once again too high, so we're going to exit this out. Acquisition slice thickness is 1.25 to 3 millimeter. Usually 1.25 is utilized and then reconned at 3. The anatomic coverage is the area of clinical interest. However, we're looking at a trauma situation. Usually the entire cervical spine is of interest. So once again, scan from the sella to T1 to T2. because we're in a trauma situation, IV contrast is not normally utilized, and that brings us to how we need to actually view these images. We usually recon always in bone, but soft tissue windows will be very essential as well, so that you can see any soft tissue abnormalities, as well as it helps visualize the spinal canal a little better. And so, and another thing is, in a trauma situation, the goal is to get the patient in and out of the CT suite as quickly as possible. And so that's what this protocol is actually geared toward, is getting the patient on the table and off the table as quickly as possible, because you're in the trauma scenario. So if you have any questions, just let me know. Send me an email, and happy studying.